Hi, Maureen.
Hey, how are you doing?
I think I got burnt.
You look a little red, yes.
Well, we were supposed to go out to Dad's on Sunday night, Monday, come back today, but weekend things change. So it's like, okay, you just make it work.
Yeah.
Been to the dump, rototilled the medium garden, rototilled the little garden, cut some trees, cut some wood. So been busy. Hi, Kathy.
Hi,
Hello.
Kathy.
Hi. Well, I'm kind of got a window behind me, but that's
Well,
okay.
I'm in my dad's computer room, so it's like I got his computer and I got my iPad.
Maybe that's a little bit better.
Okay.
Also got the window, but all right. At least I can see if I'm talking or not. And there's Louisa.
So you should be able to share the screen, Kathy.
I'm expecting Dr. Godelli to share her screen.
Okay, perfect. Well, she should be able to do it.
Oh yeah, she knows how to do this stuff. She's just a kid. Well, she's not a kid. I mean, she's a surgeon, but she's very young.
How are you, Kathy?
I'm doing good. How are you, Louisa? Nice to see you.
Nice to see you. It's been a long time.
Yeah, it has been. Yeah, a long time.
Are you still at work?
Yes.
Oh, good.
Well, it's my Zoom, as the Kona board will let you know. I have trouble with my Zoom where I live in Red Deer.
Oh,
I don't know why. And it's everything. So this is better. At least I won't fall off the planet if I'm at work.
hey, well, that's always good.
I think so too.
Yeah, and it's too hot at home, anyways.
My house stays pretty cool, but yeah, it's kind of cold here. So yeah, it's always better at work, right?
Yeah.
For air. So how do you want to wait till at 5, Maureen, and then we'll start, or is that your plan?
Yeah, we should probably wait till on the hour. More people are continuing to join, so I'll just remind people that are on the line now to mute yourself if you're not talking or asking a question.
And after I introduce things, Maureen, I'll go on mute as well.
Yep. Kathy, it's 7 o'clock, so I'm going to turn it on. I see Dr. Godelli is on the call, so I'm going to turn it over to you. I'll continue to admit people as they come and monitor the chat. And welcome everybody, and we'll turn it over to Kathy.
Hi, everyone. I'm Kathy Mullen. I'm past president of CONA. And before we begin, I just have a few housekeeping details I need to mention. So please ensure that you keep yourselves on mute. If you have questions, please use the chat to type in any questions. And at the end of our presentation, you can unmute yourself and ask a question. The chat's also going to be monitored by Maureen, and she'll ask questions as they come up. To receive a certificate of attendance, please email the CONA advertising site and you'll receive one electronically. I also want to encourage you to all renew your membership as well as encourage your colleagues to join CONA. There'll be lots of good benefits, including this evening, as you can view on the website. So thank you for joining us this evening, and now it's my pleasure to introduce Dr. Cinzia Godelli to you. Dr. Godelli is an orthopedic surgeon who received her doctorate of medicine from McGill University in Montreal, Quebec, and then went on to do her orthopedic surgery residency at the University of Calgary in Calgary, Alberta, and then went on to do upper extremity and trauma fellowship at the University of Montreal in Montreal, Quebec. She currently practices here in Red Deer, and we are thrilled to have her here. We have the privilege of having her as co-lead for the Fragility Stability Network for the province of Alberta, as well as she is the pre-op medical lead for Central Zone. So anesthesia answers to her. So we think that's great too. We are so pleased to have her speak to us, and I will now invite her to share her presentation titled Pre-op Management of Anticoagulated Patients with Hip Fractures, Experience with a Targeted Algorithm. So Dr. Godelli, I'll leave it to you. Thank you.
Perfect. Thank you, Kathy. I'm just going to share my screen here in 1 second. So yes, funny you mentioned anesthesia because we'll talk about them a little bit. So you guys can see my screen now? Okay. So yeah, I'm an upper extremity surgeon, but I do a lot of work with hip fractures. So yeah. It's interesting because it's definitely not the area that I like. I don't do arthroplasty or anything like that, but I've been working with hip fractures for a long time. So so this research project that I'm going to talk about, we got some funding with through the Bone and Joint Health SCN. So they provided administrative support and they analyzed the data, and then we had some people help. So Kathy Mullins actually did the most of the work. So her chart audits and keeping track of people really were instrumental in this, as well as she can herd people. So she gets people to do what she wants them to do, which is great, and is able to collect all this beautiful data. So so I'm going to discuss why we needed this algorithm and go through it a little bit. And then we do have this is our preliminary data. We're actually going to be looking at 5-year data because it's actually been 5 years that we're doing this. So, so why am I here? Why is an upper extremity surgeon talking about this? So this is our fragility and stability program. So we collect data provincially, and it's pretty robust and standardized. So if we look at the mortality for hip fractures, patients that have surgery within 36 hours have a 5% mortality, and those that wait more than 36 hours, their mortality goes up to, I think it's about 32.5%. And so this is just straight up all comers. But so this is the argument we used to get: isn't it the sicker patients who wait the longest, and then they are more likely to die? So we looked into the data a little bit more in depth. And so this is a graph, and it shows time to OR and the odds ratio of dying. And so it's actually adjusted for age, gender, and comorbidities. So when you adjust for age, gender, the mortality still goes up the longer you wait. So time to OR is an independent risk factor for mortality after hip fracture. And this, so this was in 2016. There's lots of papers that support this, but this is our local kind of provincial data. So I'm working Red Deer, which is in central zone in Alberta, and our time to OR was abysmal. We were 50% of our patients were making it to the OR within 48 hours. And so there were lots of reasons for this. But if you look at us now, so I took one of the best quarters we had, but it was also the quarter that was freshest when I was analyzing the data. So our time to OR for 36 hours is 94.6%. Of course, COVID has messed with this a little bit. We're still in the high 80s. Occasionally we touch the low 90s. So we're still doing really good. So we went from 50% to 95%. And it was 48 and now it's 36 hours, our benchmark. So what were we doing wrong and who are we failing? So 60% of our patient population is actually transferred in from a different site. And so some of the sites are within an hour of us, but some of the sites are 3 to 4 hours away. And so what was happening at some of our sites is they were actually getting admitted. And then they were sent here kind of whenever we had a bed. So we changed that. So patients come straight here, they go to emerge in the periphery, and then they come straight here. They don't get admitted and their transport is priority. So this is our zone. So we're right in the middle, and it's a pretty big geographical area. I think it's like the size of Portugal or something. I'm not sure. I could be making that up. But anticoagulated patients were a patient population that we were failing. So our anesthesia was really focused on spinals. We don't have a hematologist. And we used to get internal medicine consults for everyone, and internal medicine would see our patients whenever they had time. Our administrators didn't really think that hip fracture patients were a priority, and nor did the surgeons really. There wasn't that push to get them done. And then for the anticoagulated patients as well, we used to manage their reversal kind of ad hoc. We didn't know about it. We would kind of someone would give them some vitamin K maybe, and there wasn't a drive to get them done quickly. So what have we done? So we changed our transfer processes. We've educated surgeons, the emerge docs, the peripheral doctors, anesthesia. We've developed this anticoagulation reversal protocol, which is pretty aggressive. And then, so this is when we get medicine consults, which is pretty much never. And then we upgrade aggressively. So our patients don't wait, and there's no reason for them to wait. It's basically our philosophy. So this is the problem. So this is the anticoagulation cascade, and it is long and complicated. So most of us don't really understand it. So we look at it and we don't understand the drugs, and we don't understand which part of the pathway they're working at. And bleeding will stop at some point. So what we did first was we looked at, we're not really looking at making these people safe to have spinal. We're making these people safe to have a surgical procedure. And so it's changed how we do our discussion. So when we look at what the INR is and what the time interval is, we're not looking at safe for spinal, which is what a lot of the guidelines say. We're looking at when is it safe for a surgical intervention. And the surgeons, I think, will tolerate a higher level of bleeding than anesthesia will for spinal. The other thing is, we focus on spinal because nobody wants to have an epidural hematoma, but the risk of getting an epidural hematoma is quite low, whereas the risk of mortality is up to 30% for hip fractures that wait too long. So I did some lit reviews and talked with anesthesia. So overall, if you look at the evidence, the outcome for general or spinal anesthesia is the same. There's multiple papers that show this. There's been more since, but these are the kind of bigger ones when I was looking at this data. And then if you look at this article, so this article in the UK looked at a significant amount of patients, and they said they basically discovered that it wasn't spinal versus general, it was how well the blood pressure was controlled. So how hemodynamically stable was the patient during surgery. We also looked at adjuncts, so tranexamic acid. So a lot of the papers for looking at tranexamic acid in hip and knee arthroplasty are pretty good. For the hip fracture population, it's not very good. Most of them are underpowered. And then you have a meta-analysis of like a bunch of studies that are underpowered, but does seem to reduce the blood loss and less transfusion rate, and does not increase the risk of a DVT or a PE. So we looked at using adjuncts like tranexamic acid for hip fracture patients. And TXA costs pennies per dose, so it's an old drug. It's been around for a while, and we concluded that it seems to be safe and effective in hip fracture patients. So these are the algorithms. I'll go through them a little bit more in detail, but there's two. So there's one for warfarin, and the other one is for direct oral anticoagulants. So there's three most frequently used direct oral anticoagulants. There is a new one. It will be added to this, but it's exactly the same as apixaban and rivaroxaban. So it's just a matter of adding the name to it. So the algorithms were developed in 2016. I reviewed them with hematologists in Calgary, and then we just started using them. We've made a couple of adjustments along the way. And what we did was at the beginning, when we had just a few patients per group, the Alberta Bone and Joint Institute looked at the study, looked at our data, and made sure that just from the few, I think it was 10 or 15, that we were not doing anything really dangerous. And they also determined that we need about 50 patients in the warfarin group and 50 in the DOAC group to have some statistical significance. So Kathy started collecting data. So this is our warfarin reversal protocol. So basically anyone who's really high risk, so anyone who's had previous, so first things first, is we're looking for an INR 1.6 or under. So when you look at literature for spinal, the INR that they're looking for is 1.2 or 1.3. So we're okay at 1.6. So patients that have had a stroke or have a mechanical heart valve, that they have some sort of thrombophilia or any strange hematological condition, they would get an internal medicine consult, as well as anyone with a recent PE or DVT. Anyone with cancer as well, they're higher risk, but typically they don't fall into our pathway if they have cancer. So this is for TXA. So anyone that has a contraindication to TXA or Octaplex, they're pretty similar, but this is, so anyone who has a contraindication to prothrombin complex, or Octaplex, they would not necessarily follow this pathway, or they would follow the pathway, but we'd be more aggressive with vitamin K versus jumping to Octaplex. Oops. So what we do is we usually get a phone call from the periphery, from a peripheral hospital or an emerge. And the first thing we ask is that they start the hip fracture pathway, they arrange transport, get our lab work, ECG, and we always ask now if they're on any anticoagulants. So if they're on vitamin K, if they're on warfarin, regardless of whether they have an INR drawn, we ask that they administer vitamin K, either IV or orally. Again, we looked at the research, and there's not much negative effects of giving IV vitamin K, especially when you compare it to the increase in mortality of delayed hip fracture surgery. So the risks of giving one dose of IV vitamin K is pretty low compared to the 30% mortality. So once we do that, the patient comes in and we give them even more vitamin K once we see them. So again, if the INR is back, great. If the INR is not back, we still give them more vitamin K. We then do lab work, usually in the morning, anywhere between 6 or 7 a.m. And then based on that INR, we decide on whether we give Octaplex. So that decision is based on OR availability and what the INR is. So if it's trending down, if we're like pretty close, we're at 1.8, sometimes we'll just give more vitamin K. But if we're still pretty high, then we'll give Octaplex. And we do discuss the timing of when we give Octaplex, because it's only good for 6 hours. So we make sure that our trauma time starts at noon, and we make sure that the patient would be ready like around noon and not too early. So prothrombin complex is a blood product or blood derived product, and it has only the vitamin K dependent factors in it. So it's really specifically designed to reverse warfarin. So it's not really designed to reverse anything else, but just warfarin. So we tended to use FFP in the past, but it basically should never be used for the reversal of warfarin anticoagulation unless you have severe bleeding or other coagulopathy. So there's multiple papers that show that. So we pretty much don't use FFP for anyone on warfarin. So our results, so we collected 50 people between October 2016 and March 2019. Our average OR time to OR for these people was 29 hours. So 76% of them met our 36-hour target, which is actually pretty good compared to before, especially. And then the people that actually really followed the protocol, only one did not meet the 36-hour cutoff. If you look at this graph, so this is time 0, and then as we go to the right, so basically what this shows is as we got better using the algorithm, we tended to get better with getting these people to surgery quickly, and it just took some time to familiarize. To be honest, at the beginning, I would get phone calls and emails all the time asking, what should I do about this patient and their anticoagulation? Or when we would get handover emails, I would just say, no, this is not what you should be doing. Please do this. So there's a lot of micromanaging at the beginning, and now it's pretty automatic. So these are the people that got Octaplex. So pretty much everyone that didn't get that got Octaplex got done quickly. We did have 3 deaths, which was 6%. They all received surgery within 36 hours. And then we had 1 patient have a CVA, and they missed the cutoff. If you look at the analysis, so, So the mortality was actually, so the patients were a little bit older, the people that were on warfarin, and the people that died. And then we really didn't have, like, they weren't really significantly all that different other than they were older. And if you look at the reversal cost, so an acute care bed in our center is $1,500 a day versus the cost of Octaplex. So when I asked pharmacy, they gave me the cost in US dollars because that's what they buy it, is they buy it from the US. And so that dose is $600 US. So roughly, 1 dose of Octaplex, if it saves 1 acute care bed day, it's cost effective. And the administration is pretty quick. It's administered as a solution over, I think, 15 to 30 minutes. So not like a blood product like FFP where it needs to be administered over a long time. The DOAC is a little bit more complicated because there's more DOACs. Again, some people are just not great for this pathway, and those are people with thrombophilia and other recent thromboembolism, previous stroke, or TIA. Pradaxa is not really commonly used in Alberta anymore in our patient population, but there is a thrombin time blood test that you can get that actually tells you how much Pradaxa is on board. And then the most common used ones are the factor 10A inhibitors, so Xarelto and Eliquis. So these ones are typically renally excreted. So I think I go into more detail on the next slide. Yeah, so at the bottom too, so with Pradaxa, there is Praxbind. So Praxbind is a monoclonal antibody designed specifically to reverse Pradaxa. We have this available in our hospital, but again, not that many people are on Pradaxa anymore. So it's great that there's a reversal agent, but it's not an agent that's used too much. And then we did for both of them say if there's intraoperative bleeding and you haven't given tranexamic acid, consider giving it. And then you can also give Octaplex at a relatively low-ish dose, and that's an off-label use. But again, if your patient's bleeding, then you can consider giving it. So Pradaxa, or I can never say the generic name, so I never say it. But basically it works directly on thrombin, so it's a direct thrombin inhibitor. It sticks around for a long time. So for us, what we were doing is we were getting a thrombin time. And so if a thrombin time was normal, that means the patient was taking their medication. If the thrombin time was normal, it means the patient was not taking their medication, and we were fine to go for surgery because not everyone's compliant with their medication. So if their thrombin time was normal, we would just go for surgery. If their thrombin time was kind of in the intermediate zone, so less than 35 seconds, then we'd wait 24, 48 hours and then go for surgery. If their thrombin time was high, then we would just give them Praxbind and proceed to surgery. And so if you look at the cost of it, it's about $2,200 per kit. So roughly, in the ballpark of an in-hospital day. But if these people were actually being compliant with their medication, then they would have to actually wait more than a day. So in reality, it's expensive, but compared to keeping the patients in hospital pre-op, it's in the same ballpark. So probably cost effective. So we only had 6 patients on Pradaxa, and 4 of them were given Praxbind, and they pretty much all made the cutoff. I mean, one missed it by 20 minutes, so we're going to count that one as a success. Nobody uses it, so we don't get many. But it was safe, so we didn't really have complications in our Pradaxa group, although it was a small group. So the DOACs, they work on the 10A, and so they directly bind it. So what we're doing, and we're still doing now, is we do get an INR. Although it's not on our standard pathway, most people will get an INR for all hip fracture patients. So if it's normal, it means that there's probably not much anticoagulant in the system. So the Xarelto and Eliquis actually directly bind the molecules used to test INR, so it's not really a great test for INR. It's not a great test for how coagulable it is, but it just gives you an idea of how much of the anticoagulant there is in the blood. The lab actually can standardize the INR for DOACs, but as far as I know, no lab in Alberta has done that. So usually what we're doing is we're looking at renal function. So if someone has a normal creatinine, then we wait 24 hours and we go for surgery. If someone has impaired renal function, then we wait 48 hours and then go for surgery. So in Calgary and Edmonton, you can get an anti-10A assay. And if it's normal, then they're ready for surgery. But from what I understand, it takes a long time to get this. And by the time it's back, it does not help very much. Plus, we only wait 24 hours anyhow, so that's not that clinically significant. There is a reversal agent for both Xarelto and Eliquis. As far as I understand, it's not approved by Health Canada yet. Likely will be an infusion, and so it will be short acting and quite expensive. So if we can avoid having to rely on this, then that's great. So if you look at our results, so we had similar proportion of males and females. The average age, so the people on DOACs were older as compared to the people not on DOACs. If we look at the time to OR, it was not statistically different. The mortality, although higher numerically, statistically, it is not significant. So we actually had very similar mortality and morbidity between the groups. The only thing is that if you look at our time to OR, the chance of you getting surgery within 24 hours if you are on a DOAC is lower than if you're not on a DOAC. And that's expected because we put that 24-hour time delay in there on purpose. We did have some complications. So we had someone on Pradaxa who needed ICU monitoring after pneumonia. We did have some complications on people that were on the DOACs, but nothing that was out of the norm for our regular hip fracture population. So what we learned is we like this algorithm a lot. As we use it more, we're getting better. It did require a lot of education for all the practitioners. So at the beginning, our charge nurses needed some help. So did our nurse navigator. Anesthesia was a big component of this. So we had joint rounds with anesthesia and the surgeons needed some help just with moving this along. Personally, so we didn't do a formal analysis of cost effectiveness, but the cost associated with the reversal agent was not significant. It was not as much as we thought it would be. And then, we still have to use clinical judgment. So this algorithm is not for everyone. Some people will need to wait more. So I do have two patients to contrast. So this lady here has a minimally displaced fracture. She'll just get a pinning. She's relatively healthy. And has a good preoperative hemoglobin and a normal renal function. So she's probably good for general anesthetic pretty much whenever. But then we have this lady who has significant comorbidities, has a worse fracture that will take longer, has a higher blood loss associated with fracture fixation. She will not really tolerate a spinal maybe because she's already on home oxygen. She's frail, sorry, a general because she's on home oxygen and frail. Her hemoglobin sucks pre-op and her creatinine is not great. So this lady is going to have more blood loss and we have fewer options as far as type of anesthetic and adjuncts. So, while the first lady, we can go ahead, do surgery, she'll probably be fine. The second one, we probably have to wait for that anticoagulant to clear a little bit more because her risk of having an adverse event with blood loss is higher. So since we started, there's been lots of papers that have come out. Calgary has a similar algorithm, similar but different. So what we're working on now is we're actually working to collect. So we are forming a little working group with some anesthesiologists and internists from Calgary and Edmonton. And we are going to work on just making this a formalized process that the SCN, the Strategic Clinical Network, will implement across the province. Locally, we've collected more data and I'm getting ethics approval to look at our 5-year data. So we can publish this research because this was done as a QI initiative, but also so that we can publish our 5-year results, which again, haven't really analyzed that data, but just looking at it offhand, I think we do not have excessive morbidity and mortality, and we are getting good time to ORs. So those are our next step. And hopefully we will get the algorithm kind of approved by the Strategic Clinical Network by the end of summer. And ethics approval should come soon. The article's written. I just have to wait for the ethics approval to submit it. So thank you. So that's my talk there. I will stop sharing my screen. Okay. So yeah, I'm happy to answer a lot of questions and I do talk quickly. So if you miss something, please feel free to ask.
So it's Maureen. I have a question for you. With your algorithm, are you, I know that you said about rolling it out, but how are you planning to talk to the feeder hospitals who send patients, and like what's your plan for informing them so they can get started maybe before they even transfer people into you?
Yeah, so what we're doing now is it depends on the surgeon. It's really hard for us to communicate with the feeder hospitals actually, just because there's like a black hole where we're not sure who to communicate with. But basically while we're accepting each patient, we always ask about anticoagulants. And part of the process is we start it, before they leave, they should get their first dose of warfarin and get their blood work drawn. Sorry, first dose of vitamin K. Yeah. And then there is a question in the chat. So how soon do you start the DOAC or the warfarin post-op? We usually start it right. So it depends on the blood loss and the indication for the anticoagulant, but usually we can start the DOAC same day, warfarin as well. If warfarin needs to be double covered because of high risk of thromboembolism, then we'll give low molecular weight heparin and warfarin. And sometimes if we feel that there's a lot of risk of blood loss, then we'll give some low molecular weight heparin or heparin the night of, and then start the warfarin the next day. But we've been relatively aggressive with starting them again. The other thing I wanted to mention actually is, sometimes we have patients that have mechanical valves and have other issues. And while we do get internal medicine consults, what we find that we've started to do is we bring them in, we keep them on they're usually on warfarin, we keep them on warfarin, and then we just give them Octoplex. And in that 6-hour window, get them done, and then put them right back on their warfarin with whatever, either heparin infusion or low molecular weight heparin. So we've gotten rid of using as much as possible the heparin infusion pre-op, because that would be a pain to get them stabilized on the infusion. Then you have to stop it for 4 to 6 hours and then go for surgery and then start again. So we just kind of stop, like rapidly anticoagulate and then just start post-op. And so with the reverse, so with the reversal agent, so if we reverse warfarin with a ton of vitamin K, because they would probably get, half ton of it before they actually go for surgery. It does take longer a little bit to achieve a therapeutic INR. And so we do bridge them with low molecular weight heparin. Typically, we do have a hospitalist system, so they help us look after our patients. And typically it's a joint discussion about, do we, as soon as they're therapeutic, do we stop the low molecular weight heparin, or do we wait a couple days? So we will double cover them. And it does take a bit longer, but they're in hospital anyways. So these are not patients that would be discharged sooner if their INR was normal. They're kind of with us for a week or two anyhow. So. And then how do you manage patients on dual antiplatelets? Yeah, I don't know how to say that, and I don't know how to spell that, so I won't even try it, but like Plavix and the other one. We just pretend like they're not on it. So we just go ahead and do surgery. Again, it depends why they're on it. If we can give them tranexamic acid, we will. Sometimes we will get a medicine consult if there's issues with renal function and the patient's really unwell. But if they've had an MI like relatively remotely, and we don't really know why they haven't stopped the Plavix, some people are on it because they nobody's taken them off. So if we get a sense that it's that type of patient, we kind of ignore it, because those patients are usually robust enough to tolerate some blood loss, as well as like blood products, but then we will get a medicine consult if someone is frail and has significant bleed risk. And then have you looked at hemoglobin cutoffs for the algorithm? Did you look at the number of transfusions? Yeah. So ROR does not have cell savers. We did not look at hemoglobin cutoffs. We just kind of left it as whatever would be, whatever the surgeon would feel and anesthesiologist would feel comfortable with. I don't know if this will come up when we look at it to rolling out in the province. Usually if the patient has a hemoglobin under 100, we're at least cross-matching them so they can get blood intraoperatively. Like 90 to 100, they're probably going to get a unit intraoperatively. And then anything less than 90, we're transfusing them pre-op so that to compensate for the intraoperative blood loss. Kathy would probably know if we looked at the number of transfusions given post-op. I don't think we did for this, but it's on my ethics proposal for the 5-year data.
Yeah, we did. We just didn't have it analyzed, but it wasn't that significant. Hoang said actually we did have it analyzed. I made a mistake. there wasn't a significant difference between this population and the regular population with transfusion rates.
Thanks, Kathy. So yeah, we try to, I mean, there's differences between us surgeons, but we try to be relatively standardized as far as giving blood transfusions. But you know, we're not all the same. We're definitely not all the same. Our blood transfusion rate, though, is definitely lower than it was before. One thing we didn't specifically look at is using tranexamic acid. We haven't analyzed it, but again, when we do the 5-year, we're probably going to look at it. The problem with tranexamic acid is the only place it gets charted is on the anesthetic record in handwriting by the anesthesiologist. So it's not a data point that's easy to find because I can't read the writing. Kathy probably can, but that's a whole new set of handwriting you'd have to learn.
I live in Winnipeg, so we have in ortho trauma, so we have a similar system, but I would be shocked if the anesthesiologist that I work with would be willing to take someone on a DOAC within that 24-hour window. Like, I don't think I would meet many of them. So I was very surprised when I saw that that was part of your protocol.
So yeah, so anesthesia was by far the people we had to convince the most to use this. So on this committee to look at making this a provincial thing, we have 2 anesthesiologists, because one from Calgary, one from Edmonton, because they are by far the hardest sell. So this involved like hallway conversations, hallway disagreements. It was not easy, but now they're like, oh yeah, whatever. It's been 24 hours, it's fine. So they've like nothing bad has happened. And it was definitely a change management process that was very difficult. We just had to, like all the orthopedic surgeons would just never waver. And eventually I think we wore them down. But it took a long time. It took years.
Yeah, I mean, I've seen people wait for the OR like over that 48-hour mark because their INR is not on target, or people are on Plavix. A lot of anesthesiologists don't want to take people within that 5-day window for Plavix for spinals. So it would be great to have something like this similar. It would certainly help our numbers look a lot better. I guess the other interesting thing to look at would be our hospital has stopped doing a lot of GAs throughout COVID. So I know your numbers are more from 2016 to 2019, but I guess that would probably change a little bit with COVID and doing less GAs. I don't know.
Yeah, I don't think we've had a push to decrease the amount of GAs. Like I think when possible, spinal, but if it was a choice between a general and early surgery and a spinal and delaying the surgery, we would go for early surgery and a general, even with COVID. Of course, if the patient doesn't have, actual symptoms of COVID, if the patient has any respiratory symptoms, then that would change. But as long as the patient doesn't look like they have any respiratory issues, we would probably, we would do a general and early surgery. And we haven't looked at it. Our numbers obviously are not as good as they were before because our access to the OR is not as good. But I think really what changed and what allowed us to push with anesthesia is we had this data that was pretty clear that in our center, our mortality was increased because we were not getting patients to the OR in a timely fashion. And that, when presented to our administration, was very unfavorable. And they did not want to be on the books as the worst hospital in the province. So that was definitely a driver for change. And so we had our Alan Sinclair. So he's I guess he ran the hospital. Like he was our operations person who was in charge of the Red Deer Hospital. And he took me aside and he goes, my gosh, You know, when you guys were talking about reaching the 48-hour target, I didn't think you guys could do it. And now you guys are at 90% for 36 hours. He was like, I don't know how you guys did this. And I'm like, well, really, it was the right thing to do. And then once we determined it was the right thing to do, it's relatively easy to push other departments and services to help us.
Well, that's great. I would definitely like to try and get the surgeons and anesthesia on board with something like that here. So if I might have to talk to you later about that.
Yeah, no, I'm happy to like, this is my thing. I really like working on this. So I'm happy if anyone reaches out to me. By the end of summer, so working on the publication, by the end of summer, we should have a provincial one. And then once we have a provincial one, then it's kind of going to be more validated as well, because anesthesia will have had input. And so it might be an easier sell to anesthesia.
Yeah, that'd be great. Okay, thanks.
Yeah. Well, that seems to be it for the question. I'm happy to take it. So yeah, this is for anyone. Like, I'm happy. This is kind of like my pet project. So if anybody wants to reach out to me, I don't have my email here, but I can put it up actually. I'll put my AHS email because I have to check it all the time now. So yeah, I'm happy for anyone to reach out to me. And I mean, the goal is to provide good hip fracture care everywhere. And so I think that hip fractures traditionally were seen as a death sentence. And we still haven't kind of got out of that mindset. I think for some patients, they're doing poorly. They will do poorly. We can't really make them that much better, but we can maybe give them some pain relief. But there's a great, probably the majority of patients, they are going to go out in the community and they will ambulate in the community. And if we can avoid them having a complication like a CVA or something like that, like, we've really done them a service. Oh, here we go. Another question. Do you have dedicated trauma room time, or are they on call? So we do have dedicated trauma room time. So we're the third busiest trauma center in Alberta, third or fourth, particularly for ortho trauma. So we have half a day every day of trauma time, and then we dedicate it to ortho. And then we have some scramble time on evenings and weekends. So we do definitely. When we book our hip fracture cases, as soon as their consent form is signed and the ink is dry, they're upgraded to an E12, which means that they need to be done within 12 hours. E12 does not allow us to do them overnight. So anything after 11:45 is dead to, like, we can't access that time. 11:45 p.m. we can't access that time. So in the morning, so the day after their admission, they're made E6s, and then we do them within 6 hours. So we're pretty aggressive with getting them done. Thanks.
So with that, Dr. Godelli, I just really want to thank you for presenting again. I think you guys can all be very envious that we have Dr. Godelli at our site, and our numbers have definitely improved. I'm still sitting here kind of going, wow, we're doing so well. So, but a lot of it has to do with a real driver like Jinzia. So we're really blessed, and I think for her to be available for you guys to reach out to, I think just says a lot about who she is. So thank you again, Dr. Godelli.
Thanks, Kathy. Well, definitely, Kathy. I'll take 50% of the credit, and you should take 50% of the credit, because we look like we're nice people, but we're really, really, really bossy.
We're nice.
We're nice, but we're like, yeah, you know what, Kathy is patient, and she'll explain things 50 times if needed to make sure that it's done properly. So I think I'm the same way. So we just go over the same thing over and over again until it's done the way we would like it to be done.
They listen to you though, Dr. Godelli. Anyway, thank you.
Well,
guys.
thanks, guys. Yeah, it's been a pleasure.
Thank you.
Thank you.